This was the multiple determinants of health model that was used nationally at the time we developed Healthy Babies Are Worth the Wait. And although there are new versions, what we know is that the context and environment where people live is as important as the medical care in influencing health outcomes. So we need to implement not just the evidence-based medical interventions for preventing prematurity, but also to better define and implement the evidence base for addressing the social, environmental, and political determinants of health. That being said, there are still a number of interventions, both medical and public health, that we know right now can reduce preterm birth. The approach of the Healthy Babies Are Worth the Wait initiative was the vision of Dr. Carla Damas, who was then a senior scientist at March of Dimes. And she asked what would happen if we took what we know now about preventing preterm birth and tried to implement all of it in the real-world setting. Could we make a difference? She posed this question to the March of Dimes and Johnson & Johnson Pediatric Institute, who had a long-standing corporate partnership to address prematurity, and they decided to fund a demonstration project to test that question. The design of the initiative, rather than working from the traditional cause and effect paradigm, was that community partners would work together to implement bundled interventions known to be effective using both medical and public health interventions in real-world settings with the primary target of preventable preterm birth. This multi-level ecological approach was to build systems of care and support that would mediate the psychosocial and contextual factors, as well as promoting the evidence-based medical practices for preterm birth prevention. Fortunately, national discussions are now growing around similar models that focus on building these comprehensive coordinated systems of care that link clinical and public health practices. Hopefully, communities will be able to address prematurity through these models, and that funding will soon follow. The process where Kentucky was selected and chosen to be the third partner and the location for this initiative included elements that many of you would consider in a readiness assessment. A key factor was the data that would drive the focus and direction of the project. In Kentucky, we had a preterm birth rate that was rising more than twice as fast as the national rise. But Kentucky had also analyzed that data and determined that the driving force of our rising rate was actually the bigger preterm infants, as you see in the slide, those 33 to 34 weeks and 35 to 36 weeks, both in vaginal births and C-section births. These infants were later categorized in the literature as late preterm infants. So this data fit with the initiative design and the focus on preventable preterm birth, as there were indications that many of these babies were being delivered electively, both nationally and in Kentucky. Kentucky also had a high rate of potentially modifiable risk factors, especially smoking, and another key factor, of course, was leadership. Kentucky had a committed leadership at the State Department for Public Health and an active perinatal association to offer leadership and expertise in support of the initiative. According to the power analysis done by March of Dimes, we needed 12,000 births over the 3 years, and that would be 6,000 in the intervention sites and 6,000 in comparison sites. In the intervention sites, we would do everything feasible in the real-world setting to reduce preterm birth, and in the comparison sites, do nothing but monitor their trends. Baseline and follow-up data, including consumer surveys, provider surveys, policy and environmental scans, were done at both intervention and comparison sites. The 3 implementation sites were chosen for strong leadership at both the local hospital and the local health department, as we considered them the 2 health leaders in the community. The geographic diversity was also intentional. We had 2 rural settings and 1 urban setting. We chose 3 very different practice settings for the intervention. One was a private practice site, 1 university-based, and 1 a hospital-based clinic who had started centering. The comparison sites were matched on geographic similarity and similar birth populations. The intent of this model was to have enough flexibility to address issues according to each community's needs and capacity, so that when we addressed the issues, whether it was oral health or substance abuse or smoking cessation or early elective delivery, it looked different in each of the 3 sites, but it fit their local situation. So the initiative was scheduled for a 3-year demonstration project, and the primary target was to reduce singleton preterm birth rates by 15% in the intervention sites. We also hope to raise awareness of the issue of prematurity among all members of the community, and to enhance the ongoing local and national dialogue about preventable preterm birth. As we began to develop this model for possible replication, we identified 5 core components of Healthy Babies Are Worth the Wait that you see here: partnership and collaboration, provider initiatives, patient support, public engagement, and progress measures. Perhaps the most important part of any community-based project is developing strong partnerships. In this project, we were fortunate to have national partners with March of Dimes and Johnson & Johnson, who worked side by side with our state and local experts in developing and guiding this project. At each site, partnerships were built through local implementation teams, which consisted of staff from local hospitals and health departments and included nurses, physicians, administrators, public relations staff, risk managers, health educators, dental hygienists, and many others. For many of these people, even though they were working in the same communities with the same population of patients, they really didn't know each other prior to Healthy Babies Are Worth the Wait. And as they established and strengthened their relationships, the benefits accrued to the patients as the services and referral processes were strengthened and improved. We regularly brought representatives from each site together for face-to-face meetings, conference calls, and other venues, and we made a concerted effort to get as many people as possible from the sites to state and national meetings on prematurity prevention. This both increased the collaboration among the sites and kept their knowledge base current with the current state of the art. In the other 4 areas, again, we did not try to work on individual interventions, but on bundling of interventions that would work in their location. Some of these were hospital-based interventions, others were public health interventions, and they were bundled according to local needs and local capacity. Through quarterly grand rounds presentations and resource centers with current literature, we kept sites up to date on best practices, both in the medical and public health arenas. And after a grand rounds presentation, for example, we would convene the local implementation teams to sit down and discuss how their local practices measured up to the best practices they had just heard and what they could do to improve their processes. These teams were enthusiastic and always anxious to do better, learn from what worked and what didn't, and continually built better systems of care for their communities. Our signature education piece was the brain card, which came out of the focus groups we did at the beginning of the project where we tested messages. The mothers in those groups told us they needed something concrete to understand why the last few weeks of pregnancy were important. When they saw the pictures of the brain at 35 weeks compared to term, they immediately recognized the significant differences, and that became a strong and persuasive talking point. Providers requested laminated copies of this to put in every exam room so they could explain to patients who requested early delivery why that was not a good idea. This brain card spoke to all audiences, and it's been used widely now with providers, patients, and community partners. March of Dimes now has a simplified version available.